Well, welcome everyone to our first public webinar of 2022, Rural Health Quality, How CMS Initiatives Improve the Way We Measure and Address Gaps in Care. My name is Meredith Eastman, and I am a task lead for the Measures Management System. Before we begin, I wanted to note just a couple of housekeeping items. First, you'll notice that this webinar is being recorded. Second, this is a broadcast-only webinar, so your lines have been muted to minimize background noise. However, we do welcome your questions. We will be collecting questions throughout the webinar and we'll have time to address them at the end of the presentation. So please use the WebEx Q&A panel to submit your questions at any time during the webinar. Also, in just a moment, we'll be posting a poll for you to respond to inform our ongoing stakeholder engagement efforts. If you could please answer those poll questions during the webinar at a time that's convenient for you, we would really appreciate it. Next slide, please. So today, we hope that participants in this webinar come away from this presentation with a better understanding of the measurement challenges that are unique to rural areas, as well as a better understanding of how CMS is working to mitigate those challenges. Additionally, we'll review resources and programs that rural providers can use to help improve quality of care. Next slide. Before we dive into today's topic, I did want to just take a moment to review the Measures Management System, or MMS for short. The MMS is a robust system of activities and resources developed by CMS to foster and support standardization, flexibility, and innovation in quality measurement. Our team supports CMS in its work to ensure that measures are developed to the highest possible standards. To that end, we manage the CMS Measures Inventory tool. We conduct stakeholder engagement activities, including webinars like this one. We support measure implementation, and we maintain the MMS Blueprint, which is the definitive source for information about CMS quality measure development. Next slide, please. With that context, I'm next going to lay the groundwork for our discussion before we move on to specific measurement challenges that rural providers face. Next slide. But what do we mean when we say rural? There are a variety of similar definitions for the term, but generally rural communities are micropolitan, which means that they are areas with 10,000 to 50,000 residents, and these areas can include tribal areas or frontier lands. Approximately 1 in 5 people living in the U.S. lives in a rural area. On the right side of the slide is a map from the U.S. Census Bureau that identifies U.S. rural areas in green. You will note a lot of green on this map because rural areas, in fact, account for over 97% of land in the United States. Next slide, please. So now that we've defined rurality, what does it mean for healthcare? Well, compared to their urban counterparts, rural Americans are more likely to experience poverty. In 2019, 15.4% of rural residents lived in poverty compared with 11.9% of urban residents. This matters because poverty has a significant impact on overall health, with a recent analysis finding that 50% of premature deaths could be attributed to lower socioeconomic status. Additionally, rural residents are more likely than non-rural residents to live in communities that have shortages of primary care, dental health, and behavioral health practitioners. In fact, rural areas account for approximately 60% of federally designated health professional shortage areas, or HPSAs. Next slide, please. These healthcare challenges contribute to some pretty significant disparities in health outcomes for rural Americans. For example, rural residents have a higher prevalence of chronic diseases such as diabetes, serious mental illness, and maternal morbidity. Furthermore, within rural areas, racial and ethnic minority populations experience disparities in outcomes when compared to their white counterparts. For example, rural white residents experience diabetes at a rate of 6.5%, whereas rural Black residents experience diabetes at a rate of 9.5%. Additionally, if you look at the age-adjusted mortality rate, which is the death rate that controls for differences in population distribution, You'll find that this rate tripled between 1999 and 2019, with premature death rates among rural Black residents higher than premature death rates among rural white residents. Next slide. With these sobering statistics in mind, CMS is working to address the poor health outcomes that rural residents experience. The Rethinking Rural Health Initiative is a vital part of CMS's push to transform the healthcare delivery system to a model that delivers high quality, affordable, and accessible healthcare for every American. The goal of the initiative is to develop programs and policies that ensure rural Americans have access to high quality care, support rural providers and not disadvantage them, address the unique economics of providing healthcare in rural America, and reduce unnecessary burdens in a stretched system to advance our commitment to improving health outcomes for Americans living in rural areas. Next slide, please. So now we're going to take a closer look at the measurement challenges rural areas experience, as well as discuss potential solutions for these issues. Next slide. We're going to focus on 4 specific measurement challenges common to rural areas. These are access to higher quality care, quality measure low case volume, participation in value-based payment programs, and quality measure collecting and reporting burden. We're going to talk about each one of these in order. Next slide, please. And we will start with access to higher quality care. Next slide, please. So there are a number of factors that impact rural residents' ability to access care. 3 primary factors are highlighted on this slide here. The first is healthcare worker shortages. As we noted previously, 60% of healthcare professional shortage areas are in rural areas where shortages of primary care providers, dental care providers, and mental health care providers are experienced. Second, transportation is challenging because of poor infrastructure. According to the U.S. Department of Transportation, approximately 40% of roads in rural areas are inadequate for current travel. Transportation is also challenging because of limited access to public transportation related to issues associated with travel distance, frequency of service, cost, and funding. The third factor is distance to medical facilities. Rural Americans live an average of 10.5 miles from the nearest hospital, compared with 5.6 miles for people in suburban areas and 4.4 miles for those in urban areas. Next slide. You may be wondering how telehealth might help address the challenge of access to higher quality care in rural areas. By telehealth, we mean the use of electronic resources such as video conferencing to support clinical health care. Telehealth can improve access to care for rural residents by connecting rural residents to providers, including specialists, who are located outside of the patient's geographic area, and it can lessen or eliminate the need to arrange travel for most routine or non-emergent visits. Next slide, please. That said, there are challenges to accessing telehealth for rural residents. For example, rural residents have less access to broadband. Where 79% of suburban areas have home broadband, only 63% of rural areas do. Additionally, prior to the COVID-19 public health emergency, payers reimbursed a smaller number of telehealth services. And while telehealth has been in use for over 2 decades now, the ability to assess the quality of care that is provided is still developing. Next slide. There have been efforts, however, to increase access to telehealth. For example, the U.S. Department of Agriculture has invested in increased infrastructure to support high-speed broadband access. Additionally, CMS issued waivers during the COVID-19 public health emergency to increase the reimbursement rate and the number of telehealth services reimbursed. Next slide, please. So as I mentioned previously, assessing the quality of telehealth services is an emerging area, and not all telehealth is created equal. CMS and its partners are working on strategies to evaluate the quality of telemedicine to ensure that patients receive high-quality care. An important foundational step in this direction is the CMS-funded framework to support measure development for telehealth. Next slide. The framework supporting telehealth measure development identified 4 key domains or content areas, including access to care, so how telehealth increases an individual's ability to obtain services, financial impact or cost, so the cost burden for patients, providers, and organizations to implement telehealth services, experience, or how patients perceive their telehealth, and effectiveness, so how the quality of telehealth compares to the quality of an in-person care. The framework identified relevant existing measures, as well as measure concepts that could be developed to assess quality of care provided using telehealth. Next slide. The CMS-funded Rural Telehealth and Healthcare System Readiness Measurement Framework was created in response to the rapid expansion of telehealth services during the COVID-19 public health emergency. Its purpose was to identify measures that might be adapted to measure telehealth services during emergency situations. This framework incorporates unique challenges to providing telehealth in rural areas, including access to devices that allow for video or audio telehealth visits, and the specific care needs of rural residents, such as the increased risk for mental health and substance use related conditions. Next slide, please. So we've described how access to higher quality of care in rural areas creates measurement challenges, how telehealth might increase access, and emerging frameworks and approaches to measuring quality of care in telehealth. I'm now going to turn things over to my colleague Jeff Geppert, who will discuss the next challenge related to low case volume.
Thank you, Meredith. Clinical quality measures are one element of a comprehensive strategy to improve access to high-quality care in rural settings, but use of such measures must address some unique methodological issues. The low case volume challenge refers to small numerator or denominator counts in rural healthcare for clinical quality measures used in value-based programs due to sparse population. Low case volume generally means the measures have lower reliability, which is otherwise called noisy. Any differences in performance observed either across providers or across populations is likely due to random factors and not systematic factors associated with differences in quality of care. The low case volume challenge is ultimately about meaningful participation of clinicians, facilities, and beneficiaries in value-based programs. The challenge is particularly relevant for rural healthcare, but also applies to other medically underserved areas and less common conditions and procedures. Historically, efforts to address the low case volume challenge have not always supported meaningful participation of rural healthcare. These efforts might include, for example, excluding facilities with low case volume entirely, using cross-cutting measures that provide little or no information on acute or chronic conditions, or population or geographic level measures that provide little or no information for specific clinicians or facilities. A more general statement of the low case volume challenge is that efforts to address low reliability often adversely impact validity. The CMS-funded technical expert panel and final report sought to address the low case volume challenge in a manner that preserved meaningful participation of rural healthcare in value-based programs, or, in other words, in a manner that enhanced reliability and maintained validity. Next slide. Innovation is often the ability to reach into non-healthcare disciplines and bring back what is good and useful and that applies to the recommended approach in the report. These borrowing strength methods are commonly used in engineering and economics. In addition, a simplified version of the method is used in the inpatient quality reporting program, for example, in the 30-day mortality measures. The intuition behind the approach is the following. We can leverage data on other measures that have a similar quality construct to reduce uncertainty in the quality measure of interest. A specific observed value of a quality measure of interest in the current time period for a clinician or facility is more likely to be true than not true if one or more of the following three conditions holds. First, related process and outcome. To the degree that the value is similar to the values of other related process and outcome measures in the same time period for the same clinician or facility, where related means causing the same response behavior aligned with better health for patients. Or two, persistent performance. To the degree that the value is similar to the value of the same measure in a recent time period for the same clinician or facility. Or three, enabling structure. To the degree that the value is similar to the value of the same measure for clinicians or facilities with similar structural characteristics, some of which were mentioned earlier. For example, distance to an urban area transfer center, transportation infrastructure, or number of specialists per capita. The key phrase is more likely to be true, and that implies probability and uncertainty. There is no way to address the low case volume challenge in a manner that enhances reliability and maintains validity without value-based programs embracing probability and uncertainty, which may be more of a cultural change for value-based programs than a methodological issue. Next slide. The borrowing strength method holds the promise for meaningful participation of rural healthcare in value-based programs. With all the benefits to CMS, the clinicians and facilities, and the beneficiaries that such participation suggests for improving access to high-quality care. However, avoiding the unintended consequence of such meaningful participation means to ensure that reliable and valid measures do not adversely impact access to high-quality care in rural communities. The report highlights a few such scenarios. Reduced access to care because of closure of facilities due to changes in market share or financial sustainability. Disincentives to providers from offering certain types of care in rural or underserved areas based on risk of financial penalty. Encouraging providers to avoid providing certain procedures based on comparative performance, even when those procedures may be in the best clinical interests of the individual patients. An even more subtle form of unintended consequence might be the greater reliance on the structural similarities upon which the borrowing strength approach might depend. These structural factors may either be actionable if under the provider or system control, or not actionable if not under the provider or system control. Using a quality measure based on non-actionable structural factors may be considered an unintended consequence. In other words, the measure may be reliable and valid, but not usable in rural healthcare, at least from the perspective of the provider. The reliance on structural similarities may be mitigated by using the second approach to borrowing strength, leveraging persistent performance, in which case the balance between reliability, validity, and usability improves incrementally over time. But allowing for this improvement over time may also be a cultural change for value-based programs. The borrowing strength methods do require a complex infrastructure to support. and infrastructure that is not yet widely available. The next challenge will address current participation of rural healthcare and value-based programs. So at this time, we will turn the presentation over to Kim Rawlings at CMS. Thank you.
Thank you, Jeff, for outlining that second challenge of low case volume. As he mentioned, in this section, we're going to highlight several initiatives that really encourage, increased participation of rural providers in value-based payment programs, which, we hope will then have an overall increase in participation, which will have a positive benefit on health outcomes. Next slide. So generally speaking, at a high level, CMS value-based programs reward healthcare providers with incentive payments for the quality of care that they give to both patients and individuals. These programs are part of really a larger quality strategy across CMS to work towards reform on not only how healthcare is delivered, but also how healthcare is paid for. Value-based programs support better care for individuals while promoting better health for communities as well as lower costs. Next slide. And a couple of examples, previous slide. A couple of examples of value-based programs that you've probably heard of include like hospital readmission reduction program, end-stage renal disease, quality incentive program, and skilled nursing facility and value-based purchasing, just to name a few. And historically, rural providers have experienced challenges participating in these kinds of programs, really because of that second challenge that Jeff just went over of low case volume, which is when rural providers do not have enough resources to accurately report on quality measures. And as Jeff pointed out, the borrowing strength method may allow rural providers to meet the minimum numerator denominator to report a quality measure. However, like you said, this methodology is not yet widely adopted. As such, across the entire federal government, obviously including CMS, we've been seeking other ways to promote participation in value-based programs for providers in rural settings. And so this is not something that CMS can do alone. We cannot do this work in isolation. And so to support quality reporting, the Health Research Services Administration, or HRSA, another department within HHS, designed the Medicare Beneficiary Quality Improvement Project to promote voluntary quality reporting by critical access hospitals. Just as some background, a critical access hospital is a designation given to eligible rural hospitals by CMS. The designation is designed to reduce the financial vulnerability of rural hospitals and really improve access to health care by making sure that essential services stay in rural communities. And so to accomplish this goal, they receive benefits such as cost-based reimbursement for Medicare services, among others. And so the program identified a list of existing quality measures most relevant to critical access hospitals and grouped them into 4 categories that you can see here. So the categories are patient safety and inpatient, so things like antibiotic stewardship. Second, patient engagement, such as HCAHPS Composite 2, which is around communication with doctors. 3, care transition, so again, like HCAHPS Composite 6, which is about discharge information. And then 4th, last but not least, outpatient care, such as median time for ED arrival to ED departure for discharge ED patients. Next slide. Another important way that CMS tries to mitigate challenges for providers in rural communities is by granting them and all stakeholders an opportunity to provide early, direct feedback on measures that are proposed to be used in CMS quality programs. And so one avenue for that is through the pre-rulemaking process. CMS uses pre-rulemaking for the pre-rulemaking process for the selection of measures for use in specific Medicare quality programs. The purpose of the pre-rulemaking process is to allow the public and expert feedback early in the process of CMS considering measures in our program by making time for stakeholder feedback prior to rulemaking, hence the name pre-rulemaking. To ensure the voice of rural communities is present and considered, CMS funds a Rural Health Advisory Group that is part of the Measures Application Partnership organized by the National Quality Forum to review these measures under consideration across 19 Medicare quality programs and provide feedback on their perspective to be integrated into recommendations to CMS about these measures. Next slide. One of the more recent initiatives that's come out of the Consolidated Appropriations Act is around rural emergency hospitals. So in 2020, Congress established a new provider type, rural emergency hospitals. The rural emergency hospitals comes as a response to really like an ongoing period of hospital closures in rural communities and to the concerns of access to emergency services in rural areas. And so rural emergency hospitals may provide an option for communities that are perhaps like too small to support a full service hospital, but then like really need more care than what ambulatory care can provide. And so beginning in 2023, rural emergency hospitals will report on quality measures that will be available to the public on the CMS website. And these measures are required to go through the pre-rulemaking process that I just outlined, and they'll be going on the 2022 measures under consideration list to be reviewed by the Rural Health Advisory Group later this year. It is initiatives like these I just outlined that really work together to increase the voice and perspective of rural communities in measurement in many of our value-based programs. Next slide. Now moving on to the final measurement challenge we will discuss today. We'll be discussing quality measure, the collection and reporting burden of quality measures. Next slide. So rural providers experience challenges in data collection and reporting similar to, though to a greater extent, than their non-rural counterparts. First, they may not have the staff they need to collect the data. Some measures do require a lot of effort to collect the information needed to report. This can include either manually going through medical charts to find relevant information, which obviously we're trying to move away from chart-based measurement, or it can be about going, collecting patient-reported data through assessments, and that can, have a certain amount of burden attached to it and need staff efforts. Second, there can be a significant cost to maximize the technical health information systems to report measures. Many rural health providers are part of smaller practices that do not have as many financial resources as their larger suburban and urban counterparts. Next slide. And so in part, to help address collection and reporting burden, CMS launched Meaningful Measures 2.0. This work really promotes innovation and modernization of all aspects of quality by addressing a wide variety of settings, stakeholders, and measurement requirements, including rural health providers. One of several goals of Meaningful Measures 2.0 is to transform measures to fully digital and work to incorporate all payer data. One of the challenges for rural providers that we've discussed is the time and effort that it takes to report certain types of measures. And so by transforming our measures into digital quality measures, that can alleviate much of that burden since they use health information sources that are reported electronically. However, it is very important to acknowledge that digital quality measures can alleviate workflow challenges for providers, that while they can, alleviate workflow challenges to providers, many rural health providers will need time to ramp up their electronic record-keeping capabilities to enable electronic transmission of measured data. Next slide. So in addition to trying to simplify measure reporting, Meaningful Measure 2.0 also focuses on measure alignment to reduce burden on measures. It's important that CMS not only align internally across our reporting programs, but also externally with private payers as well. And so as such, we have two initiatives to highlight. First, the Core Quality Measures Collaborative, or CQMC, and the CMS, and then two, the CMS Cross-Component Alignment Work Group. The Core Quality Measure Collaborative is a partnership between America's Health Insurance Plans, or AHIP, CMS, and the National Quality Forum to create core sets of measures to align quality measures used by public and private payers. And the goal of this group is to create an agreed-upon set of core measures that can be used across payers to reduce burden associated with reporting on similar or on competing measures. Then the CMS Cross-Component Alignment Work Group is an internal work group to CMS that aims to align the use of measures first and foremost across CMS programs. However, we do really take into account the consideration of measures used by other federal agencies as well as private industry, where possible, particularly with the respect to the Core Quality Measure Collaborative core sets. And similar to that group, the goal of the alignment work group internal to CMS is to try and reduce the number of unique measures in the CMS portfolio in favor of a more parsimonious group of measure families that represent the highest priority improvement areas that can be used across similar programs. Next slide. And so to delve a little bit deeper into the Core Quality Measure Collaborative, I just wanted to outline the three principles that guide the creation of their core set. So first is to promote parsimony. So this means the use of fewer and more meaningful measures. The second is alignment, so the selection of measures used across different programs and payers. And then third is efficiency of measurement. So really choosing the minimum number of measures and the least burdensome measures. While the CQMC core sets are intended for all providers and payers, there are several core sets on conditions that really disproportionately impact rural residents. And we'd say that those are behavioral health, cardiology, and obstetrics and gynecology. Adoption of these core sets by public payers as well as private payers can really reduce the number of measures rural providers report and then thus reduce burden. Next slide. The last topic that we're going to discuss today, though definitely not the last initiative at CMS to address quality measurement in rural communities, is the technical assistance made available to providers. In addition to the policy and structural efforts to reduce reporting burden, CMS and HRSA provide technical assistance, or TA, to rural providers to help them report quality measures. As touched on previously, the Medicare Rural Hospital Flexibility Program, or FLEX, helps critical access hospitals to improve rural healthcare quality, financial health, and hospital operations and EMS. And so with that, I'm going to turn it over to Kate for a summary and then Q&A.
Wonderful. Thank you so much, Kim. So we've covered a lot of information today. To summarize, rural residents experience disparities in healthcare outcomes compared with non-rural residents. And we discussed a lot about how quality measures are a tool rural providers can use to measure and improve the quality of care their patients receive. CMS is working with rural providers to support high-quality telehealth care, address measurement challenges that impact providers' ability to report, and increase participation in value-based payment programs, and reduce measure reporting burden. So we want to take a moment and ask people, if they have not already done so, encourage you to sign up for the newsletter. My colleague will put it in the information in the chat function. And the MMS newsletter is something that you can receive to get information on quality measurement announcements, events, and opportunities to get involved. So if you haven't done so already, highly encourage you to sign up for the listserv, which will be in the chat function. We can move on to the next slide. So we want to thank everyone so much for joining us today. Thank you to our speakers and to everyone who has been able to join us. The contact information is at the bottom of the slide. And so if there are any follow-up communications you would like, you can contact Patel as the MMS support contract holder, which is mmssupport@patel.org. Kim Rawlings is our core, and her information is on there as well. Thank you all so much for joining us, and we hope you have a wonderful rest of your day.